The equipment needed for aspiration includes a 16-gauge or 18-gauge over-the-needle catheter tubing with a 3-way stopcock, and a 50 milliliter or 60 milliliter syringe to administer local anesthesia. You will need 1% or 2% lidocaine, a 10 milliliter syringe, and 22-gauge or 25-gauge needles. Explain the procedure to the patient and obtain written informed consent, confirming the patient's identity. Place the patient in a semi-supine position with the torso at a 30 to 45 degree angle to allow the air to collect at the apex of the lung. Administer oxygen and monitor the patient's pulse oximetry, heart rate, and blood pressure. An intravenous catheter should also be in place. Finally, provide the patient with a face mask. The preferred location for placement of a needle for aspiration of pneumothorax is the second intercostal space, in the midclavicular line. On the side with the pneumothorax, begin by locating the second and third ribs. The second rib is the first palpable rib that can be felt just below the collarbone. Then locate the third rib. The second intercostal space is the area between the second and third ribs. Next, identify the middle of the clavicle and the midclavicular line, and the intersection of the midclavicular line. And the second intercostal space is the correct place to insert the needle for aspiration of pneumothorax. It can be helpful to mark the needle insertion site with a skin marking pen. Use chlorhexidine or another antiseptic solution to clean the patient's skin in the area where the aspiration will be performed, and position the sterile drape. Aspirate lidocaine into the 10 milliliter syringe for use as a local anesthetic agent using a 25-gauge needle. Inject a wheal of lidocaine at the superior edge of the third rib at the midclavicular line. Switch to a 22-gauge needle and anise to tie the deeper layers of tissue by inserting the needle at an angle perpendicular to the skin. Before injecting the anesthetic, always aspirate the site to make sure the needle has not entered the blood vessel. Progress with the needle just over the top of the third rib through the intercostal muscles in the direction of the pleural space. This will prevent injuries to the intercostal vessels and nerves, which lie just below the rib cage. Once you have inserted the needle through the intercostal space, continue to aspirate. When you penetrate the pleural space, air bubbles will appear as you aspirate. Before you remove the needle, note the depth of penetration. You will use this depth as a reference point. When you insert the over-the-needle catheter, connect the over-the-needle catheter to the 10 milliliter lidocaine syringe, which should be partially filled with the remainder of the local anesthetic. Stabilize the skin with the non-dominant hand and puncture the skin with the catheter using the same landmarks that you used for the local anesthetic. Continue to aspirate with the syringe, slowly progressing in the direction of the pleural space. Again, when the needle penetrates the pleural space, air bubbles will appear in the syringe. At this point, move the needle forward a few millimeters to allow the catheter tip to fully penetrate into the pleural space. The appearance of air bubbles will confirm that the catheter has progressed into the pleural space. Ask the patients to exhale or cough to prevent air from being sucked into the pleural cavity. Remove both the catheter needle and the 10 milliliter syringe. Then immediately cover the opening of the catheter with your finger to prevent the entry of additional air into the pleural cavity. Attach the tubing with the 3-way stopcock to the catheter. Use the 50 or 60 mm syringe to gently aspirate the air from the pleural space, evacuated through the side port into the ambient air. The correct manipulation of the 3-way stopcock is crucial, as the connection of a side port to the ambient air will entrap air in the pleural space and increase the pneumothorax. The volume of air that is aspirated can be determined by counting the number of syringes evacuated. If more than 2.5 liters have been evacuated, the procedure should probably be stopped because such a large volume suggests that there is an air leak. Continue manual aspiration until you cannot aspirate any more air. Remove the catheter. Put a sterile dressing on the site of insertion. And order a post-procedural chest radiograph to be obtained with the patient in an upright position.